So knowledge is obvious, but it's not enough to say knowledge and experience. There's this old saying of somebody visiting New York, and you ask a New Yorker, how do you get to Carnegie Hall? And the response is practice, practice, practice. So, we could simply say that, get more experience. And we know from Erickson's and other work, it's deliberate experience we need to get, but we really need to try to understand more what that knowledge looks like, how it's structured, because in fact, understanding that will really help us structure our learning experiences, probably in very different ways. So Benner's early studies in nursing in the early 80s really revolutionized, I think, how we think about knowledge. At that time, many of us, scientists, saw knowledge as a formal structural knowledge, something that one gains from scientific study or from theoretical underpinnings to our work. Benner pointed to the kind of knowledge that's embedded in practice, what the experienced clinician knows and sees, all the kinds of cues and patterns that are in the environment that is handy, ready at hand, available, easily accessible by the clinician. Similarly, work by Patel and others in the 90s, Bordage, among others, in medicine, has brought forth the kinds of knowledge that are evident in medical practice. Schmidt, another investigator in a summary, categorized the kind of knowledge available to clinicians in 3 areas that look basically like a medical school curriculum, not incidentally, of basic science being sort of foundational illness scripts or schemata that really are packages of the 27 signs and symptoms of congestive heart failure, for example. And then finally, exemplars, whole experiences of an experience with the patient that often are recalled in this early encounter with the client, this whole initial encounter. Beyond that, beyond these exemplars, then this is the kind of knowledge that is brought to bear on the practice. And we find that more experienced clinicians, in contrast to beginners, are more likely to bring forth these exemplars as a comparison to what the case is in front of them, that often is the basis for our clinical judgment. It's this whole pattern recognition. Early studies focused on the notion that clearly there's reasoning that draws on this basic science knowledge, but the studies have been unable to really find where experts use the basic sciences to bring that forth in clinical reasoning unless the clinician is stumped. And in some fields like neurology or nephrology, we found that clinicians more often refer back to some of the basic science reasoning, the anatomy and physiological alterations that may result in these signs and symptoms. So other factors, though. Knowledge doesn't explain it all. Knowledge doesn't explain at all how a clinician, what the perceptual grasp is that a clinician gets when they begin this encounter. And we find that there are also a number of biases that set up what a clinician notices. There's work out of the group in Oregon, Kahneman and Tversky and others who have studied the biases in estimating probabilities of events, and biases such as the availability bias. In other words, if you can remember a similar case, you rate the likelihood of whatever was going on in that similar case as being much higher than instances that may not be so available to memory. That these biases in that way may influence what you notice and pay attention to. Similarly, and on a not so great note, we've had a number of studies that really show factors, non-clinical factors, such as the patient's socioeconomic status in the emergency room, determining what the kind of diagnostic tests that clinicians will do and the kind of diagnoses are actually considered beyond what that socioeconomic status might have to do with the patient condition. That those biases are often built in, unbeknownst to the clinician, in the way that they engage in the clinical situation, what they pay attention to. I want to just comment briefly on the ethical perspective and what I mean by this. Research in moral reasoning, ethical reasoning, has also gone on quite independent of the work in clinical reasoning. It's quite interesting. Yet, in our forefront always are a set of ideals, a set of values that are part of our professional work that we hold dear to us. And we find also in our studies of nurses that there are certain aspects of care that nurses almost feel a moral obligation to see that they're carried out. So we all know, for example, that generally there's undertreatment of pain across many settings in hospital-based care. And yet various units hold a culture and a belief, as do individual nurses on that unit, toward pain management, that no patient should be uncomfortable, no patient shall have a pain level above a certain point. And that view, that perspective, actually sets up whether nurses notice or pay attention to the pain that patients are experiencing. If nurses hold that value, that comfort of patients is an ultimate good in nursing, that totally shapes how they engage in clinical reasoning. And it's absolutely critical, I think, to our practice. And finally, we've learned how much knowing the patient really matters in our clinical reasoning, both knowing who this person is as a person and also knowing what that individual's patterns of responses typically are. How does that patient typically respond? What do they typically look like? Is this different from that kind of typical pattern? And so that's central to our practice. And finally, along the bottom of the slide here, what spans all of this is the context of clinical judgment. And I think we heard yesterday a wonderful presentation around the culture of safety. And the unit culture, the culture of the organization, what's deemed important in that organization also influences and sets up what a clinician notices and pays attention to in a clinical situation. Now, one might say, well, we teach our students to be systematic. We go through systematic head-to-toe assessment. They learn to look systematically for things to avoid biases. Even with that, when in a busy day-to-day practice, what clinicians pay attention to is what they've had past experience with. It's things that may be influenced by bias. It's what they see as counts as important in their discipline. It's what they know is important to this patient, and it's what's valued and important in the unit. A severe noticing failure. I can't tell you how often I've heard students say, "Oh, I didn't notice that," when as a coach I would call attention to something that was really critical to their understanding of the clinical situation. And so I think that aspect of our reasoning is really critical for us to think about as we move into looking at how we can affect simulation. So in studies in both disciplines, and actually some additional studies in occupational therapy I'll mention, that we've identified two major streams, easily coded as analytic and non-analytic reasoning patterns. And I think probably most people are familiar with the classic work of the 70s that we've discovered how both physicians and nurses engage in situations when they really don't know what's going on. When they've noticed that something's happening, very early in the encounter, clinicians begin to generate diagnostic hypotheses, trying to get a sense of what's going on with this patient. And it may be a medical diagnosis, it might be a broad inference about the kind of problem, but this sort of frames and shapes the subsequent collection of data, that the data that the clinician continues to collect in their exam through laboratory is a focused assessment that goes toward ruling in or ruling out those hypotheses. Well, it turns out in studies in medicine that what's in that initial set of diagnoses is very, very important. That studies in diagnostic error point out that some large proportion of diagnostic error can be attributed to not having the accurate diagnosis in that initial set. So that's critically important that we capture it early on. In the non-analytic pattern, one approach that has been written about more extensively than others is pattern recognition. What Benner and Tanner and others have referred to as intuition is noticing and recognizing a pattern instantly and being able to act on that pattern. Now, there have been studies that explore the question and the belief that is pattern recognition sort of the secondary strategy, that it's really not, it's inferior to the kind of analytic approach that comes from a systematic assessment and a process of diagnostic reasoning. And there's some fairly convincing arguments by Norman and Eva that, in fact, it's the systematic, the hypothesis generation analysis approach that leads to much more diagnostic error. And that pattern recognition, this understanding, this immediate grasp of a situation, an immediate recognition of a pattern and taking action on it ends up often and correctly being the appropriate response. I suspect there's not a clinician in the room that hasn't had a phone call from a nurse at some point saying, you know, there's something going on with this patient, and I need you to come see this patient. And physicians have learned to listen to some nurses when they tell them that, because often it's a correct assessment. There's something going on where there may not yet be clinical signs, obvious clinical signs of a patient getting into trouble, but the nurse recognizes a pattern that may be similar to some previous experience that calls forth the need for some attention, some deeper exploration. And it's a phenomenon that nurses know very well. I think many of us know that gut feeling, that gut sense that things are going to go awry. And physicians know very well when they've paid attention to that kind of call and recognize it. It's a very important aspect of our practice. What Benner's work also points out, though, is that the skilled nurse knows not to just accept the immediate recognition, but go into a process of saying to him or herself, do I have the right understanding of this situation? Do I have it really well in hand? And goes through a process of analytic reasoning to assure that, in fact, they have the right grasp of the action. A third approach to reasoning that's been described slightly by Montgomery in her work, and a little bit more extensively by Benner's work, and also in occupational therapy, is what might be termed narrative reasoning. Very different from the sort of analytic, propositional kind of reasoning that we see in many of these studies, but really gets at the notion of understanding the patient's perspective through hearing their accounts, their narration, their stories of experience with health and illness. Many of you may be familiar with the work of Kleinman and other medical anthropologists that showed and studied the narrative components of illness, how every illness, every symptom has a lived experience with it, and understanding what the patient's understanding of that illness is, understanding how they've learned to cope with it, understanding how they interpret it, what meaning that brings to them, is really critical to how we approach our clinical situations. It's really critical in the practice, at least of nursing, and how we understand that person's perspective. As we hear these accounts, we hear these stories of their experience, and it helps us understand what's important to that person and what strengths they bring, what ways they have of coping with it, and very important to our work. So I'd put that as yet a third approach, or maybe we'd want to class it in the non-analytic approaches. Once we have a grasp or understanding of what's going on in the situation, then what's possible for the clinician to take action, and often the clinician acts very quickly on the basis of a recognition of the pattern. Now, interestingly, there's very little in this descriptive research about management decisions. How is it that clinicians derive decisions? And there's also very little in the research, and I would hope for more in this whole area of how do clinicians partner with their patients in coming to decisions about the best course of action. How do they create a collaboration with their patients in order to arrive at the best decisions?